Hello, it's Eric from Strong Medicine. Today in this series on notes and presentations, I'll be giving two demonstrations of a classic SOAP presentation. These are the presentations that medical and APP students and interns frequently give to their teams while on the hospital wards. If you haven't already watched it, I recommend first viewing my video on the format and content of SOAP presentations. While nearly all services in American hospitals use the general SOAP format for presentations, there are modest differences in length and content between different institutions and different specialties. These presentations will model what would be expected on a typical internal medicine or IM specialty service. However, the general principles will still apply to surgical and pediatric specialties. Lastly, for those viewers who have already seen my two H&P demonstrations, you'll note that these will be the same patient cases as those, one of acute heart failure and another of sepsis, but as they would be presented on hospital day number 3 after the patient's conditions have changed following 2 days on treatment. Ms. Harris is a 76-year-old woman with hypertension and a prior MI who presented 2 days ago with acute decompensated heart failure in the setting of new-onset AFib with RVR. Overnight, the night team was paged by nursing due to new-onset confusion and modest agitation. The covering resident assessed the patient at the bedside and felt that she was experiencing mild hospital-acquired delirium. Vitals and exam were unremarkable, aside from her AFib's ventricular rates reaching back up to the 120s. The resident opted to hold off on labs because of good urine output, lack of infectious signs, and because the patient's agitation improved with redirection. This morning, subjectively, she reported little memory of the events of last night. She's been feeling less dyspnea this morning, but is not yet back to her baseline. She has no chest pain, palpitations, or lightheadedness. She had a good appetite for her breakfast, which had not yet been delivered. Regarding her exam, her vital signs, she remains afebrile. Her heart rates were 110s to 120s during her delirious episode as mentioned, but otherwise have been 80s to 100s, with blood pressure 100s to 120s over 60s to 70s, respiratory rate 18 to 22, O2 sat of 93 to 97%, and eyes and nose were 1.8 in and 3.2 out for a net 1.4 liters negative. Her mental status appears back to her baseline, and she was oriented to 4 out of 4. Lungs had mild bibasilar crackles that are improved compared to yesterday. Rhythm remains irregular with a JVP that is now normal for the first time this admission. Repeat POCUS was deferred due to limited time. Mild symmetric lower extremity edema to the upper shins is unchanged. CBC and BNP were unremarkable aside from a potassium of 3.2, which was orally repleted. Telemetry over the past 24 hours shows consistent AFib with 5 episodes of NSVT, the longest of which was 8 beats. So in summary, Ms. Harris is a 76-year-old woman with hypertension and a prior MI presenting with acute decompensated heart failure with a new EF of 30 to 40%, hypothesized to be secondary to tachycardia-induced cardiomyopathy. She is hemodynamically improved with diuresis and rate control, but now with an episode of hospital-acquired delirium overnight. Problem number 1, heart failure. Given her improving symptoms, improving O2 sat, and normalized JVP, I think we are nearing euvolemia. Diagnostically, cardiology wants to hold off on additional ischemia workup for now and to follow up as an outpatient to discuss whether or not to pursue testing after recovery from this admission. Therapeutically, for diuresis, we will continue Lasix 20 milligrams IV BID for today with a goal of another 1 to 2 liters negative, and tentatively plan on switching her to oral Lasix with tomorrow's AM dose. For afterload reduction, she remains on her outpatient lisinopril and amlodipine at the moment, but we anticipate transitioning her to Entresto prior to discharge. We would also like to start empagliflozin today. Problem 2, her atrial fibrillation. After tolerating an esmolol drip for the first 24 hours in the admission, she's now cautiously remaining on 12.5 milligrams Q6 of metoprolol tartrate with a heart rate goal of less than 100 to 110. Cardiology plans to proceed with a TEE and likely DC cardioversion once she's euvolemic, possibly as early as tomorrow afternoon. If cardioversion is successful, I anticipate amiodarone to maintain sinus rhythm, but we'll defer to cards on that. She also remains on apixaban for anticoagulation. Problem 3 is her delirium, which appears resolved for now with non-pharmacological interventions. Given its resolution and her reassuring exam and labs from this morning, additional workup is not indicated at this time. Nursing requested an order for PRN quetiapine, but I'm holding off on that because if the delirium were to recur tonight, I actually would want the patient reassessed and not just sedated using a PRN order that's already there. Problem 4, hypertension. As already mentioned, she's currently on lisinopril, amlodipine, and metope, though this regimen will likely be changed prior to DC. Problem 5, her CAD. Continuing aspirin and atorvastatin, workup for ongoing ischemia deferred as previously mentioned. Finally is Dispo. Hoping Ms. Harris will be able to DC back to her home in 2 to 3 days, once euvolemic and in sinus rhythm, provided that she's cleared by PT and OT, and her family can increase the level of in-home support. Social work and case management are currently working with them on this. Ms. White is a 38-year-old woman with no relevant chronic medical problems who presented 2 days ago with septic shock secondary to Staph aureus bacteremia and cellulitis. Overnight, she spiked another fever to 39.1 in the absence of any other new symptoms, prompting a repeat set of blood cultures. Subjectively this morning, she reports still feeling, quote, crummy, but is overall better than yesterday and is in better spirits. The dyspnea present on admission is now resolved. Her right leg pain is improving, but she still does not feel well enough to walk around on it independently. She used her PRN 5 milligrams of oxycodone 3 times yesterday. On exam, vitals from the past 24 hours include the aforementioned Tmax of 39.1, T-current is 37.5, pulse 70 to 95, blood pressure 106 to 122 over 72 to 84, respiratory rate 16 to 20, and O2 sat is 95% to 98% on room air. Eyes and nose have been even. Lungs are clear, cardiac exam still unremarkable, including no murmurs, no evidence of endocarditis on extremity exam. The warmth and tenderness of the right leg has receded to just below the knee, which she can now bend freely without joint pain. On labs, her white count is 12.5 from 13 yesterday, and creatinine 1.7 from 2.0. Anion gap remains normal, and no new lactate levels within the last 24 hours. Admission blood cultures were updated this morning and now identified as MRSA. TTE yesterday had good views and revealed normal cardiac function with no vegetations or other valve problems. There is no other new imaging. So in summary, Ms. White is a 38-year-old woman who presented with septic shock secondary to MRSA bacteremia and cellulitis, complicated by acute lung injury and ATN, which required a 1-day stay in the ICU for critical care monitoring, but improved without a need for vasopressors or positive pressure ventilation. Problem 1, MRSA bacteremia. Given her improvement and the final ID of the organism, we are narrowing antibiotic therapy from Vanc plus cefepime to just Vanc alone. We're currently planning on a 14-day course of the Vanc, which will require a PIC once blood cultures are negative. Given that the TTE from yesterday was a high-quality study and completely normal, and the lack of any peripheral findings of endocarditis, we're holding off on a TEE, but if her repeat blood cultures are persistently positive, we'll discuss this decision with ID. Problem 2 is pain control. I discussed with Ms. White options for treating her right leg pain, and we are in agreement for continuing the current plan, which is round-the-clock Tylenol and PRN Oxy 5Q6. Problem 3 is her acute kidney injury secondary to ATN. I'm reassured that the creatinine is mildly improved today and urine output is good. No specific diagnostics or treatment indicated. We will continue to monitor with strict eyes and O's and daily chemistry panels. The next problem is her acute lung injury. As her O2 requirement and lung exam are both normal, this appears resolved, which is what we would expect given her sepsis improvement as well. Last is her dispo. I anticipate that she'll be discharged back home pending placement of her PICC line, which will take at least another 2 days while waiting on the repeat blood cultures. In the meantime, we are continuing PT and OT and encouraging her to get out of bed as much as tolerated.